And I think every Vietnamese people with the last name Nguyen is a majority, so it's completely okay. We know that you are calling us. So hello, thank you for the introduction. My name is Trang, as you already heard, and I want to share an example of what we do in Vietnam regarding the stimulant, people who use stimulant drugs. So a stimulant is, especially methamphetamine, crystal meth is on the rise, still on the rise in the Southeast Asia region and the East Asia region. And this is the data from the World Drug Report in 2024, showing that currently it is still on the rise. It has been for the past 10 years and continue to be. So this one is a current concern for the government in the region, as well as for the communities working with people who use drugs. And this is a HIV epidemic in Vietnam. We see some decrease in the 2014, 2016, and then we see it on the rise again in 2018, 20, and currently still on the rise. And the sexual transmission is now the main route of transmission for HIV in Vietnam. And the authorities emphasize that this has a linkage with the use of methamphetamine rising in Vietnam currently. So for HIV epidemic, people are now concerning with methamphetamine use as well, and so for the communities for the past 10 years. But we don't know how to deal with it initially, because Vietnam is also one of the countries receiving funding from international donors like PEPFAR or the Global Fund for people who inject drugs. But when people use new synthetic drugs like methamphetamine, they smoke, they inhale, and they don't inject. So what do we do about it? We cannot just distribute needle and syringes or send them to methadone clinics. So it's very important that we have a program focusing specifically on harm reduction for people who use stimulant drugs. So at SCDI, we have a literature review and we have consultations with the community. We develop the project firstly from the report from the communities that now currently people are using methamphetamine and there is no program for them. So what can we do about it? So it started with the community's voice, and we added the literature review showing that methamphetamine use does not only affect the behaviors of people that leads to HIV transmission, like unsafe sexual behaviors or mental health issues. But it also, we also found literature review showing that methamphetamine use reduce CD4 and also increase the replications of HIV-1. That means that methamphetamine use does not only affect the behavior, but also the pathogenesis of the disease. So in order to deal with HIV issue and drug use issue, we have to deal with the other factors associated with it, including the mental health disorders, the childhood traumas that associate with mental health disorders, and methamphetamine use, and unsafe sex. So that is how we identify the issue associated with our program related to people who use stimulant drugs. So based on the literature review and the voice of the community, we developed the interventions. One of the core interventions is still HIV. The second one is harm reduction, specifically designed for people who use stimulant drugs. So it is completely different than needle and syringes or methadone program. And we also focus on mental health interventions and reducing the impact of adverse childhood experiences, because we see that it leads to mental health issues and also leads to drug use among especially young people who have childhood trauma. And on top of that, we developed the chemsex intervention because of the sexual transmission, and the use of methamphetamine use is initially focused on people in the men who have sex with men community. But we also found so many more people practicing these behaviors outside of the men who have sex with men community. So we screen people for the risk. Each client coming to us will not provide us with any information of their name or their address, but they will provide us with their fingerprint, which help us to identify them individually. So when they come to us, we only know them for their code. And for the HIV intervention, we developed this one as a community-based program. So every single step was done by the community. As you can see here, they do the counseling for HIV and they do the testing for HIV by the communities, and treatment adherence support and counseling for treatment, and counseling for viral load tests after 6 months and 12 months. For the harm reduction interventions, this one is a tricky one because we don't know what to do, and we also are not sure about the type of substances are being used outside of methamphetamine and heroin. So we test people for the substance that they use, and we use the ACID screening tool by the WHO to identify the risk associated with drug use, and also provide the counseling that we design specifically for stimulant. One of the counseling message that we do is eat, drink, sleep, and repeat. It sounds simple, but there's a science behind that. People who use stimulant, they lose a lot of energy, and they are stimulated, so they are dehydrated. So we advise people to drink, but not just saying that drink water, but we help people to identify what is the trouble that you are having with stimulant use, and drink water can help you regain your energy and reduce the level of substances in your body, and so on for eat and sleep, and repeat the cycle. So every single one that we touch, we deliver the message to them, explain to them the reasoning behind eat, drink, sleep, and repeat. So we have a structural counseling based on that. So it's some of the examples that we did. For the mental health intervention, we screen people for mental health. And based on the data in Vietnam, there is only 0.52 psychiatrists for 100,000 citizens in Vietnam. That means that we don't have enough psychiatrists for treating people in the general population, let alone the marginalized population, like people who use drugs. So we have to do the screening by the community themselves. So we develop a tool with the support from experts from France. So some of the issues that we screen are anxiety, depression, suicidal ideation, suicidal attempt, and psychosis, because people use methamphetamine. So these questions are also specifically designed for people who use drugs. So we screen them, and we provide counseling by the communities to them to identify the risk first. And when the score is higher than the cutoff point, which is 11, we refer to the psychiatrist. So we reduce the burden for the healthcare system, and we we empower the community to support themselves. And some of the tips that we provide for the clients on mental health is also very simple and can be done by the community. One of the techniques that we use is scaling technique, which help people to choose how are you feeling today. You choose from the scale from 0 to 100, and then based on that, we initiate the conversation on mental health. Why are you feeling that? What can we do to help you with that? So it's simple and it's applicable for the community and the client. And I will pass through this. For adverse childhood experience, we organize activities that we call healing circles and art-based therapy, which help people to deal with the trauma that they have gone through with people with the shared experience. So only people who have the score of adverse childhood experience score of more than 4 based on the scale of WHO, then they identify as qualified for this intervention. So they share the experience, they use drugs, they are young, so they form a group to support each other with the facilitators from our team. And in our project, we have 7 provinces and cities, and we reach a total of 10,105 people. And among them, we see 82% identify themselves as people who use drugs and not MSM as reported in the national data. And we divided into 2 groups of young people from 16 to 24 years old and people above 24 years old. The type of substance use, most methamphetamine, majority of them use methamphetamine. We are surprised that it's no surprise that in the group of older generation, above 25, we see a lot of people using multiple types of drugs. And for young people, it's more methamphetamine and ketamine and cannabis. But what surprised us is the first use when people started using drugs. For the older clients, they say that they use drugs when they are 19 to 25 years old. But for the younger clients, they say that they started using from 15 to 18 years old, which means that the age of people start using is now getting younger. And this is HIV status. It's not really high, but we still find new clients who never been tested before in the HIV program. And this is a result of the mental health issues that we found among our clients, which is for older generations, the rate is so much higher, around 58% is positive for the quick screening tool that we use, but for younger one, we have 21%. And there are also confirmed in our logical framework that many risky sexual behaviors are shown among both groups of the clients, under 24 and above 24. And the sexual behavior and the mental health issues is also closely related. We found that among the people who practice chemsex, also more than half of them also have mental health issues. For the men who have sex with men, more than 2/3 of them have mental health issues as well. So same for people who do sex work and people who practice group sex. So, and drug use and mental health is also positively correlated with each other. And some of the intervention outcome, when we do everything from screening to counseling and supporting people to access to treatment and providing information for people, we found that the condom use has been increased after 6 months of interventions with the clients. However, we also see that there's an increase in the chemsex practice and group sex practice among the clients. And we did a qualitative focus group discussion with our clients to identify the issue, why after receiving information there is more chemsex and more group sex. And we heard from our clients that they didn't tell us the truth of their chemsex practice in the beginning of the project. No one in Vietnam, as an Eastern country, no one talk about sex to a first-time stranger. So they have to wait until they are familiar with people to share about that. So we learned that during our work. So we see that we still have a lot to work on chemsex intervention. And the drug use, we use assist again among our clients, and we see a significant decrease in the level of risk of the client. This one is only shows a high risk of methamphetamine use, but we see a significant decrease. So that means that our intervention for harm reduction is now working for the clients. And same for the mental health. Even though the interventions provided by the community is so simple, we still see a significant improvement before the intervention, and after the intervention, the positive score for quick screening tool has been decreased. So we have strong evidence that there's correlation between substance use and mental health, HIV, and high risk of sexual behaviors. And because of that, a multi-dimensional approach toward people who use stimulants should be applied. And we find that community-based interventions work. Everything that has been done is done by the communities, and the result, as you already see. So that is our message. It can be done and can be done effectively. Thank you.
Thank you very much. We still have 1 minute for question. I just wanted to start with one, but please think about any quick questions you have. You mentioned mental health support for people, which is very important. And I wanted to ask you, for many harm reduction programs, we hear that people find it difficult to find either mental health professionals to give support, or they do not have funding for that, or that staff who is not a mental health professional doesn't have training to deal with that. How do you do that? What type of professionals are giving mental health support? How do you fund the work?
In my presentation, it shows that 58% of the people in the older generation, above 24, not older, and the young generation, 21% of them have the positive score for the quick screening tool for mental health that we use. And we know that there will not be enough doctors for supporting all of the clients. So community support is there. So that is the reason why we train our community outreach workers to provide the counseling by providing them with the simple tips of reducing the mental health issues or identify your emotions or coping mechanisms for your stress, because people use drugs is also as a coping mechanism. So that's what the communities can do and has been doing. Only the people with suicidal thoughts, suicidal attempts, and people have psychosis, we ask the communities to refer them to the psychiatric hospital. And even the support for accessing is also much needed with the community support, or else there's a lot of stigmas towards mental health that has been going on. So without them, clients will not be identified as being crazy and sent to psychiatric hospitals. So yes.
Thank you. Okay.
Thank you so much.
That's a very quick one.
Yeah. Why do you think there's a shift happening to meth use? Is it because it's cheaper? Is it more available? What happened then?
First of all, it's more available. And for younger generations, they don't inject. In our project, we don't see much people injecting drugs, especially the young generations. They don't associate themselves as people who use opioid or heroin, where they are addicted when they are very in vulnerable place. They identify using stimulant drugs for parties, for stimulating themselves, to engaging with friends more, to be more confident on themselves. So it's not as pain relief as the older generation, but it's more having fun in the younger generation. So yes, supply and the pattern of use.
Thank you very much.